Hi, I'm Jordan McDonald, staff writer with GovCIO Media and Research. And today I'm joined by Lance Scott, the CTO of FEHRM, Chris Nichols, the program manager of EIDS at DHMS, and Alexander Dixon, senior director of Defense and Veterans Health Technology at Maximus Federal Services. We've got an amazing conversation on data modernization in health IT, and I'm excited to have all these panelists here with me. Hello, everyone.
Hello. Good morning. Thank you.
Morning.
Lance, I did want to start with you. Could you help me understand through the work that you do at FEHRM, what are some of the best practices that you've uncovered for ensuring data standards between partners are able to maximize collaboration?
Sure. Thank you. So I'm going to harken back to my days when I was first learning this area. And I used to think that data standards were pretty cut and dry, that you just had to, it was very simple to start exchanging data. And it really turns out to be much more involved with that. You've got to agree on who you're going to exchange data with. You got to agree on the method that you're going to transport the data, whether it's FHIR or any number of ways to transport data. You gotta come to an agreement on which domains you're going to exchange. You would think that would be very easy, that all healthcare organizations would just exchange all health data, and that's absolutely not true. We used to have to go through negotiations with each partner way back when we first started this as to which domains were going to be actually exchanged. And then we had to look at what format those domains are going to be in. And last but not least, we had to always think about security. How are we going to protect this? How are we going to get guarantees on both sides, both how we're going to treat the data and how they're going to treat the data? The best advancement I can look at is the way we currently do business now. We basically got three pillars of data exchange in the joint HIE. Three different organizations: eHealth Exchange, Commonwealth Health Alliance, and Care Quality. They all exchange data in very different ways, but we've cobbled it all together. So we've got basically the largest health information exchange in the world. But we're always looking to improve. How can we do that better? And the formerly known organization as ONC came up with the Trust Exchange Framework and Common Agreement, TEFCA. That is going to take us to the next level in creating these qualified health information networks, basically taking all those areas that I talked about before and standardizing them so that, in theory, once you connect to one QHIN, you get data from all the other QHINs. So I say in theory because that's not in practice yet. The Federal Electronic Health Record has not decided on a QHIN. We're probably 10 and 12 months out from making a decision as to which QHIN we choose. But I guess I'll go back to my original premise is that exchanging data is really more than just agreeing on a standard, and you really have to pull the thread on all the pieces.
Mm-hmm. Chris, are you seeing that as well?
Yeah, no, absolutely. And I think part of the biggest piece of that is really data literacy, right? And that's a very broad term, right? Because in the analyst community that are in the data every day, there's a different level of data literacy and understanding what is needed, I think. But even at the executive level, there has to be a better understanding of data and what it's used for, because there is this perspective in many ways that there's magic that happens, right? And there's processes that have to be put in place, technical, and getting that better understanding of data literacy, where an organization can really leverage data, what data, and how to do something with it is the critical component. I'll take data quality as a piece of this because it's a big piece of what we're talking about right now. You really have functional, technical, and analyst output data quality issues. And I say functional because if the data coming in is bad, that's a process issue, right? That's a human process. The data is not being put in where, unfortunately, it needs to be put in. That piece will change over time with technology, right? Because we're going to get to the point that you have the ability to fully scan records and pull the data out. And we're doing that in with some language processing capabilities already today. But like if you look at the EHR, if the right data is not put in, you can't expect it to be out on the other side to be leveraged for productivity or business analytics and analysis, et cetera. The technical data quality is exactly that. We have to combine those things, integrate that data. And then there's the analyst piece. If you have 100 analysts answering the same question, you're going to have 100 different answers because of the lack of consistency in what the analysts are using that data for, or if they're a business analyst, a clinical analyst, et cetera. And the way we're kind of getting at that is really around OMOP, Common Data Standards. And OMOP is it's actually an international standard in healthcare. And so when you say an encounter, it means here are the 7 things that account for an encounter. And that means it's the same for if you're in the clinical space or the business space, the medical logistics space, or whatever that may be, not encounter for logistics. But I say that because we've done a lot of work to map all that data to these standards, but now it's really up on the analyst community to start to fully leverage that. And the honest truth is there's a workload there because they have to rebuild their queries and rebuild those things. And so, but going back to the executive piece where Lance was talking about with TEPCA and all these other things, that at the more leader level, they have to understand what's possible and the art of the possible and what work needs to be done to put these things into place. I think Lance and Alex would probably agree with me. As you see these public conversations coming out about large language models and all these different things and all the work that's being done in the space, there seems to be this magic assumption. There seems to be this assumption that magic can happen on the back end. And when you're in the federal government, you've got the layers as well on the security aspect of things that have to be put in place so things don't move, unfortunately, as fast. There's a lot of people right now that want the things to move faster. We're doing those things where we can. But I think a big piece of that is education and training and awareness at the data side, but also at the executive level side, and understanding how governance impacts this as well.
Alex, Lance and Chris have sort of helped us understand the importance of data standards and literacy. I want to pull the conversation back a little bit. Could you help us explain or understand how, I guess, all this ties together? How is the data so critical? Why is the data so critical for these health IT modernization goals that we're talking about?
Yeah, thanks for that question, right? I can't overstate how important data is in healthcare, right? And I think, and Chris and Lance both touched on interoperability, getting data across to the right spaces, right? So it's really critical to harness that data to improve patient care, to improve public health, to improve operational efficiency, and improve health outcomes for our patients at the end of the day. Modern health IT systems, right? They're leveraging interoperable, standardized data across electronic health records, patient portals, health information. Now, harnessing that data and getting to the point where you are analyzing patient data, analyzing that clinical data, and enhancing early interventions, early disease detection, public health biosurveillance, and kind of combining that data with, let's say, non-clinical information so you can determine access to care issues, social determinants of health, and really get a whole health picture of that patient. That's where we're moving toward, right? So the important piece of it, right, you have to recognize the importance of the data when you're doing your digital modernization. And that means you have to prioritize those decisions on your data management systems, your infrastructure, the quality of the data, the standardization of the data, the integration of the data, interoperability of that data, and of course, the security of that data when it comes to healthcare. So if you're not prioritizing these decisions when you're designing your data management systems early on, the modernization is not going to be as effective as you need it to be. So again, can't overstate the importance of data in healthcare today. And as Chris and Lance were touching on, and just to take it a step further, there are so many uses for this data, and there's so much data from an analytical standpoint, whether, there's clinical data, there's business data, there's process optimization data, there's clinical research data, and there's all different users across the ecosystem who want to use that information for their own mission and objective. And we've got structured and unstructured data. We have petabytes of data. And Chris can probably speak to the true size of what is in the information platform right now. But being able to orchestrate that data and make sure it's available for that analyst, for that user to get to the information they need for their mission. I mean, that's kind of the true goal of leveraging that data to enhance health. And that's the key component here.
Alex, you mentioned these large quantities of data, and throughout the discussion already, we talked about the complexity of interoperability and managing all this for analysis. But Lance, could you help me understand, from your perspective, what are some of the challenges involved with this, as you're tackling this modernization effort?
Yeah, absolutely. I'm going to echo what Alex said. He stated very well about it's really more than just data in terms of treatment. Like 90% of the time, I deal with health data for treatment purposes. But every once in a while, I get into the analytics or something like that. But mostly, it's just for treatment, and that alone is absolutely massive. One thing I learned a long time ago is that one of the biggest blocks to clinicians today is information overload. There's just so much out there that they to try to maximize the extremely short amount of time that a clinician has with a patient. They need to get the right data at the right time as quickly as they possibly can. Now, and then I'll give a comparison. I talked about the three legs of the joint HIE. One leg is very much what I consider like rudimentary 1.0 data exchange. When a clinician sits down on a computer, they say, I want all the records on Lance Scott. It kind of shotgun blasts it out to hundreds of thousands of partners and said, do you have any records on Lance Scott to give back? Well, we've got another partner who has what's known as a record locator service. And when you look for certain records, it basically knows where records for Lance Scott are and only sends out queries to those locations. I consider that kind of a 2.0 version of looking for data. And the last but not least, this is something Chris and I have been working collaboratively on, is in natural language processing. How do we get to that needle in a haystack to make the most use of the clinician's visit with a patient? How can we maximize exactly what a clinician's looking for? Do some content searches on that data and say, hey, oh, by the way, clinician, here's all the data, but this is the data that conforms to what you're looking for that visit: traumatic brain injury or a back problem or something else. And I really see that as a progression of how we get to that needle in the haystack, and we're definitely going that direction for the tough QHINs in the future. So our job is never done. There's just such a massive amount of data out there. We just have to look for better, more efficient ways to get at the right data.
I think, to Lance's point, I mean, we're at an inflection point in many ways right now. If you've heard of Moore's law, compute doubling, and that started in the 70s, that's thrown out the window at this point in time. Because in the data space, we're not doubling, we're tripling, we're quadrupling consistently. That affects so many components, right? It affects the bottom line of the cost to store that information and put it in the right storage mechanisms. And it affects the amount of information, to Lance's point, that's coming in front of the user every day. I think we're going to be in a situation in the future, this all changes, but where we're at right now with technology and the amount of data is we're at that inflection point to figure out how to fully leverage it and consistently use it the right way to answer our questions. But Lance, something Lance said and Alex said, I want to highlight too. So by background, I'm actually an ER critical care nurse. So I actually care about the patient, not that everybody else does, but I say that because we have to also be careful about the data and think about it in the business side as well. Because if the business is not healthy and supportable from a financial perspective, and I say any business, right, then the outcomes of using that data for clinical care and impacts to the patient aren't going to be there either, right? And so there's that middle ground that we've got to work towards in the business and administration of healthcare and the clinical provisioning of healthcare. If you look at military medicine, we send over 50% of our patients out to to the purchase care side, to out in the community care. And we've got to integrate that care with what's happening in our direct care system. And then, partnering with Lance and others, we got to integrate that with how we leverage it with the VA and other federal partners, NIH, CDC, HHS. And so that's the critical inflection point that I think Lance and I are always thinking about, at least from my perspective, is the business, but then also the health of the business being the health of the individual, but the health of the organization, because that has to be combined when we're looking at all this information.
Mm-hmm. So, Chris, you talked about the business side of it, and Lance, you mentioned the information overload. My next question is obviously going to go to Alex and ask, where does industry tie into all this, and what contributions could you bring to help reach these goals and to tackle these challenges that they both mentioned?
Thanks for that. I mean, I think the industry does have the ability to shift investment as needed, right? We're constantly scanning the new technologies that are out there. I mean, Lance and Chris both talked about like data overload, right? Well, there's also product overload on the market right now, right? Everybody has the newest whiz-bang technology that can help you drive down to the answers you need to do what you need to do with your data and move things along. We have the ability as vendors like Maximus, like other companies, right? We can set up test beds, right? We can implement procurement steps faster than a lot of public entities can as well. And we can bring those products into our test bed, into our test environments, sandboxes, whatever terminology you want to use. And we can try those out, and we can work with customers to give those a chance and see if they really do hit the mark in terms of moving the needle forward with what needs to be done with the data management system and how to get to the right answer as quick as possible, right? We also have a lot of partnerships across agencies and across vendors, right? So one agency, let's take the DHA and DIMS and the FEHRM as an example, right? A lot of great interaction with other agencies across the federal health space. Companies can also interact with civilian agencies or other defense agencies, see what's working there, and bring those best of the best ideas to the table, back to EIDS and DIMS, back to the FEHRM, back to DHA, whatever it might be, that we can kind of build the bridges between these entities. Maximus does a lot of work with other federal civilian agencies who use a lot of data. The ones that come to mind are IRS and SEC, as well as CMS. But from an IRS and SEC standpoint, financial data, slightly different than health data. However, still secure, still protected information that we need to ensure is getting into the right hands for the right analysis to be done. So we can bring those lessons, those experiences, and again, those sandboxes to help test out some of these products, make sure they're going to work for the mission. And we can do that slightly faster than a lot of public entities can because of the regulations and budgets and everything else that they have to hold true to.
And so thinking about doing things slightly faster and thinking about this information overload and how to manage it. We talked about industry, but I also have to ask about emerging technology and the role that can play in helping to, either procure data faster, secure it, analyze it. And so, Chris, could you help me understand the potential, I suppose, of emerging technology?
In this space that we're in, technology is moving so fast. And so I always say to the team and others when I'm talking, we want to get ahead of the curve. The answer is we're never going to get ahead of the curve, especially in the federal sector. We want to stay as close to the curve as possible, right? And I think that's where my perspective is. And Alex made the comment that there's product overload, and so one of the big things is looking through everything, figuring out the wheat from the chaff, or whatever that term is, and the noise ratio, and making sure that the noise stays away, because it's really about focusing the right technologies on our strategic intent and what we're supposed to be delivering, right? And then also understanding from a roadmap perspective, from a security perspective, how quickly we could onboard something already. Does it have reciprocal ATOs out there from another federal entity? What is it we're really trying to accomplish and deliver is the bigger conversation I think that has to be discussed because of the security implications and other capabilities there. But we can talk about all the cool buzzwords right now, but everything's moving so fast that we have to be thinking 5 years out, because honestly, what's in our head right now, 5 years out, is honestly probably 18 months out, in my opinion. I remember having a conversation 3 years ago and saying, a lot of this isn't really going to matter in the data space in 15 years, because ultimately a physician is going to pick up his phone, they're going to dictate, and it's going to magically not just be a blob of text, but flow into the right format to be leveraged in that EHR, right? And so, like I said, 10 to 15, I said that 3 or 4 years ago, I said probably 10 to 15 years out. I think we're 5 years out from that. And then that changes the paradigm too, that we were taught, that Lance was discussing, on how do we leverage that data and the data overload too, right? And so I think those are the things that I'm thinking about in the emerging technology space, from a strategic perspective than looking at each tool as a tool.
Alex and Lance, I see you both smiling, nodding your head.
It was well said, right? And I think going back to, again, the overload, right? We're dealing with both data and product. There are so many products out there, and they all promise answers to what you need. There's a tendency to get lost in the product technologies, the specifics, the steps, and lose the user experience, use the customer experience, lose what does this mean to the health of my patient? Like, what does this mean to the public health in the United States? And is it going to get us the answers that are going to drive to the objectives and the mission that we have, right? There are little goals, there are little objectives you want to achieve in your data management system, or to provide data to the right people at the right time, in the right format, right? But you can't lose sight of what we're trying to achieve, what we're actually trying to get, and to provide the technologies. We're not looking for technologies at the end of the day. We're looking for answers for clinicians, so they can be better, so they can treat the patient better, so they can introduce new treatments, new diagnoses, capabilities, right, to move health decisions faster, health delivery faster, and make sure that patient is healthy for the near term, long term, right? I mean, that is the goal at the end of the day. So we can't get too riled up in individual technologies and what is going to be used. But I think it's everything Chris said is spot on, right? Keep your eyes on the ball, right? It's all about health and healthcare and healthcare delivery.
Mm-hmm. And, we're talking about this vast amount of data that's, entering this space, I suppose. How does the creation of more data open up like more areas for access for potential threat actors? And Lance, how do you, I suppose, manage that risk?
Yeah, it really does. You heard me say earlier about the truly massive amounts of data that we have out there. And one thing is, more data is going to equal larger threat surface. You expose yourself to different vectors of attack from bad actors. But what does it really mean? What you're saying, if you've got more data, chances are it's because you're onboarding more partners. And when you onboard more partners, we kind of got a trust but verify mentality here, that you do trust people to exchange data, protect the data, the way that you all agree to, but you have to verify that as well. I mean, I may be a little bit biased here, but I think the DoD has a pretty, as kind of the gold standard in cybersecurity. So they're not perfect, but they do a very good job. And the DoD, the VA, and all the federal EHR partners have agreed early on that there's one gatekeeper, and that is DoD security, that at our main hub where we keep all the data. They are, as I said before, a crack team. They're constantly looking at new vectors, doing cyber tabletops, doing pen testing, anything they can to try to, as Chris said, not get ahead of the curve, but at least stay on the wave. Stay as close to the cutting edge as they possibly can, because as we've all seen, nobody wants to be find themselves in the middle of a ransomware attack or anything where health data is compromised.
Mm-hmm. And so you guys are also the partners in this scenario. Chris, how are you, I guess, working to ensure security of this data as well?
Same thing Lance is saying. I mean, I think we have to deal with cyber. It is a circumstance that we are in the technology space that we are part of. And I think continue to build out that footprint and that support, and doing the right pen testing and doing the right adversarial management of these issues is the critical component. I agree with Lance that I don't think DoD cybersecurity is perfect. None of it is, right? It changes when you talk to cyber experts in industry as well as in the Department of Defense. It's moving so fast, just like everything else in technology, is that we are always playing keep up, right? And from an adversarial perspective, and it's just ensuring and continuously ensuring that from an executive perspective that is a priority, because it's easy to be allowed to be lost. And when you lose it and it's too far down the priority list, that's when it becomes an issue.
And so, like, Alex, I'm trying to you help me wrap my head around the balance, I suppose, between ensuring the security of the data while also making sure that it's effectively shared between partners. Sure. So to help improve decision making.
It's a key challenge. I mean, balancing security and data access for effectiveness is one of the main issues that we have to deal with. Like, when you make security too cumbersome, I mean, users are going to be less effective with how they implement and use that data. They might get frustrated, right? They might not adopt that new technology. They might not be willing to use that new data platform or what it might be. Or worse, they can try to seek ways to bypass security, which does increase the risk of data breach. Now, like, again, most of us kind of came up in the DoD, right? And security has to be paramount, right? We've seen too many instances in healthcare in general, not just public, but private as well, where there have been data breaches, right? There have been cybersecurity attacks on certain applications. So security has to be the most paramount element of protecting the data for sure, right? And ideally, you're going to be able to find that balance by what we like to do is try to implement the automation on those cybersecurity controls, try to make it as back end to the individual. They don't necessarily see it, but they have to verify their credentials along the way. And we didn't get into it before, but I mean, the DoD, the rest of the federal government's on this zero trust architecture journey, right? And it's changing the perspective on protecting the networks, changing the perspective on protecting the applications from guarding the door, guarding the gate, to basically assuming the threat is already inside, right? And so you're maintaining this constant verification and authentication and authorization of those persons or non-person entities who are inside your network, right? And that does make it a little more difficult. Now, no one is fully through the zero trust journey. There's still quite a few years left, but we're talking identity, credential access management, like not just role-based access management, but attribute-based access management, some really smart access controls, just in time and just enough access capabilities to make sure folks, the users who need access to the data, have access to that data that they need to produce or need to get to. But we're also seeing, like, again, multi-factor authentication and high-level encryption, certainly for data at rest within the system. Now, it's not just the data at rest. I mean, the value of the data is the sharing, the interoperability, the interconnectivity across, whether it's federal health or even private health organizations. So Lance mentioned FHIR standards, making sure those interoperability standards are in place for secure data exchange, making sure you're using secure APIs, right, that have transport layer security, even end-to-end encryption to make sure those folks are authenticated, are authorized to access the data within your system as needed. But I can't understate that it is a major challenge, right, for federal health entities. The benefits come in when there is interconnectivity between private and public health entities, right, which as Lance mentioned, opens the door, right? It opens the door to access into vulnerability, into potential threats. So if there's a way to ensure the zero trust principles as we move along that journey are embedded or engaged both on the public side and the private side, which necessitates those private entities to potentially invest a little bit more in their cybersecurity elements. But as long as those are applied at both across both networks, we want to try to secure and validate authorization, authentication of any entity that's accessing the data. And ideally, we'll see more automation coming into play, whether it's RPA or other types of automation or capability from a cyber monitoring perspective, a threat vigilance perspective, that ideally, again, make it easier on our cybersecurity operations teams, as well as don't interfere with the user's ability to get access to the data they need access to when they need it.
Mm-hmm. And gentlemen, that like brings me back to something a way I want to wrap a bow around the conversation and ask, starting with Chris, like how, I suppose, can all this data be shared between agencies, drive that interoperability, drive that effective, while increasing that effectiveness that we've been talking about throughout in order to make sure this data sharing isn't as, let's say, cumbersome as Alex put it?
I think it's part of it's developing the right architecture model as well, right? Because if you have the right, and I'll use an example, we're with the research community in the Department of Defense, military health specifically, a vast majority of research that goes on is with extramural partners, and that's folks at universities, civilian universities, et cetera, partnering with researchers on the DoD side. We can't let them come into our networks. They're not cleared at the right level to have access to the PHI. So we're building the right architecture, IL4, IL2, so that we can have that de-identified data come into an IL2 environment that they can access. We're also doing something very similar in sharing genomic material sampling, not human, but wastewater, air, et cetera, with labs. Labs are being collected all around the world for the DoD and being able to integrate that with the other data. So that to me is an architecture issue. And the other big piece is that word no one likes to talk about, and that's requirements, right? And priorities. What are the priorities? And that needs to drive in all these different domains the work and the focus of what needs to be shared, how it's shared, and then ensuring that it's shared appropriately.
Mm-hmm. And so, Lance, could you sort of help me understand from your perspective what the firm is doing to drive this interoperability?
Sure. I go back to something we talked about earlier. I'd say probably a decade ago was when I first entered the healthcare data space, and I was doing an operational assessment on one of my systems up in New York, and I was schooled as to exactly how many different electronic health records there were. There was 160 different systems just in New York State alone. Now multiply that times however many states. You're talking, not only do you have hundreds of electronic health record systems, but then on top of that, you have hundreds, if not thousands, of different healthcare information exchanges. So my hat's really off to the creators of TEFCA and going to the Qualified Health Information Network. I really see that as an advancement to the nirvana that I naively thought that we might be able to get to a decade ago. That well, it wouldn't be easier if just everybody exchanged all the data in the same format. And I was very quickly corrected as to exactly how bad it was. We've come so far. We're not there yet, and we probably never will be completely finished. However, I think TEFCA QHIN is really going to be a step in the right direction to increase data sharing in the healthcare community, and the firm has played a big role in shaping the TEFCA standards. I'm proud of that. We believe in it, and we're looking forward to it.
And Alex at Maximus, I know you're doing a lot of work to drive this interoperability as well. From your perspective, how are you working to increase that effectiveness?
So I think we have a focus on customer experience, right? I mean, if I was to say the legacy of Maximus really is a customer experience, customer focus philosophy. So we're embedding that within our data operations capabilities, right? To bring the right blend of technologies, infrastructure, governance, like the preparation of the data, orchestration of the data. We touched on some of these before, to really implement controls, but as well as like access and ability for users to get the data that they need when they need it to meet their objective, right? And it's got to be the right data, right format. However, we want to make that as automated and as efficient as possible. So, I mean, we're really trying to blend the technologies, and we're agnostic, frankly, to the underlying technologies that are brought to the table, whether it's things that are related, obviously, cloud computing, big data platforms, low code, no code platforms, any analytical tools, any orchestration tools, right? We're not married to any one product vendor. So we can work with customers. We are working with customers to make sure we're blending and combining the best technologies that make sense for their mission and what they're trying to achieve, right? So, I mean, with that, I mean, it is dependent on what is to Chris's point, what is the requirement? Like, what is the objective? What is the goal? What are you trying to achieve? And we always maintain that what does the user need, right? And there's so many different users of this data, which again, we follow down the human-centered design, persona-based path of understanding who the different users are, what they need the data for, when do they need to touch that application or that system, how are they using this data, and what is it going to result in, right? What is their objective to meet that? And we balance the solution based on what that user needs, what's going to move them forward to meet their objective, while maintaining security, while maintaining scalability of that underlying platform, and frankly, making it as seamless as possible with other components, other systems, other applications within the big network infrastructure.
Absolutely. Gentlemen, we've had an amazing and interesting discussion on health, data modernization, health IT. I wanted to throw it your way if you had any closing thoughts.
Thanks, Alex.
I'm good.
Thank you.
Thank you.
Well, gentlemen, thank you so much for joining us. This was a very fascinating, interesting discussion with some great leaders in the health IT space. And, I'm really looking forward to seeing new developments, how emerging technology and how interoperability between you all will help drive better health IT outcomes. Thank you so much.
All right. Thank you.
Thank you, guys. Have a good one.